And so January, February, March is when we'd expect activity to occur, and a completion date any time in that time frame. But more likely February or March to finish the current year that we've already started. So we'd almost be halfway through the fiscal year before they actually start. Before we know what the appropriation process is, and we're looking for what we call a restoration of funding. Getting it from that $2 million level we're at currently up to 10 to 20 to 29 million. Our number we're asking for is 29 million, but there's different levels of activity that can occur at different levels. It depends on what the Congress ultimately decides, and we are competing against other things like the funding for NIH, for Pell Grants, for Title I education. So it's a zero-sum game competition that we're in with many programs that are funded within that same appropriations bill. So we've got kind of two things. Another thing that's another activity that's going on behind the scenes while the appropriations process plays itself out on the Hill, and either, again, there's two options. Either they get something done in a lame duck, or they wait till the next Congress reconvenes in January and work it out then, and they resolve it by Congress. But there's an intervening activity that we helped instigate, which is getting the administration to find money within existing resources that they can transfer, essentially, from other programs to the lead program, and keep that money going to grantees and the state health departments to continue, at least at a minimum, surveillance activities. And so we've been, Rebecca and I and others have been working with very senior level people within the administration, and just to name a few, we've been at the Office of Management and Budget. We know this is on the radar screen for the Domestic Policy Council. We know it's on the radar screen for the senior health advisors for Secretary Sebelius. We've been in communication with them. There's the Assistant Secretary for Health, which is Howard Koh, which has a senior role in overseeing all of the public health service agencies, which is the CDC, HRSA, NIH, and SAMHSA, others. It's on his radar screen personally, and we've been working closely with his assistants to kind of move the discussion along behind the scenes to see where, within existing resources that are, that the HHS has in 2013 under the CR, under the continuing resolution, can we get money out to grantees to keep this program going before Congress acts? So that's already kind of teed up. I think everything's in abeyance until after the election. Soon after that, we'd expect them to be kind of in coordination with the Appropriations Committee, deciding is this going to be handled and finalized and dealt with by the Appropriations Committee on the Hill in the kind of the November time frame, or will the administration themselves find resources to put out on the street to grantees to keep this going? And we're talking about keeping it going through the rest of 2013, the year we're in, which it started on October 1st, of this year, through September 30th of next year. And it may require new competition, and it may not. They're looking at all possibilities, but we've done kind of as much as we can to kind of tee this up for either option to occur, and we're working, with all parties, bicamerally, bipartisan, to make sure this is on everyone's radar screen as decision makers, and we have kind of two venues for action here: the Hill, the Congress, if they're going to move forward, and if they don't, to see if the administration can get this done on their own with money they have kind of in hand. And both are viable options politically, as well as kind of legally. And we're just going to have to kind of wait a couple weeks, and then I think hopefully a trigger will be pulled either by the Congress or by the administration to get money out to grantees. But we're hoping to get up to at least the $10 million level for 2013 to keep the surveillance activities going at a minimum. Working with Congress, we could probably potentially get back case management services and get to higher funding levels, and that certainly is our goal. Our goal for the year is $29 million, and that's what we've been working on throughout the year. So let me just stop there, and I know if folks want to ask questions, they can do it through the chat, and Rebecca will pose the questions, and we'll answer them.
Thanks so much for that, Mark. So far, no questions have come through. I did want to let people know that the webinar slides will be available as well as the recording after the fact, and you'll get a link that will take you to that. So, Mark, thanks so much for that, and maybe if you can just linger for about 5 minutes, we'll see if any questions come through, and I'll keep going.
Sure. Yeah, I'm happy to do that. Okay, thank you.
Thank you. And just so you know, folks, this is the report language that accompanied the $10 million that the Senate included. As Mark alluded to, the focus really has been on surveillance. We've been really pressed by both the administration and by the appropriators to express and explain why case management cannot simply be picked up and covered by other programs or other sources of funding such as Medicaid. Why is there the need for a separate appropriation for CDC? And while there's good reasons why that has not occurred, I do think that we need to explore some of those options, and that's part of the reason that I have John and Tom and Delilah on today, is to talk a little bit about what they're doing locally. There's a lot of reasons why Medicaid can't cover all case management services. You have eligibility issues. You have the fact that not all children. I think John gave me the example of Cleveland. 50% of the kids with EBLs were Medicaid enrolled, and then the other 50% are not. So it's not a silver bullet solution, but there's a lot of feeling among the White House officials and the appropriators that the healthcare reform, ACA, provided new opportunities to cover public health services that maybe previously had not been covered through either private insurance or public insurance. For those of you, I think, what we're really hoping is that you'll take the time this week, in addition to the other activities that you're doing, to reach out to your members because they're at home. They can meet with you in person if you reach out to them. At a minimum, making phone calls to let them know about this program and why it's important. Here are our house targets, so if you see your state on there, know that you are blessed, politically blessed, as Cornerstone tends to say. Here are our Senate targets. And I know many of you have already done outreach, so this is just a good time to check back and say it's National Childhood Lead Poisoning Prevention Week. Here's what we're doing in the state, and here's why this issue is more important than ever. There's a lot of ways that you can do this. The simplest, most straightforward way is to get on our CapWiz Legislative Action Center and send a note. We've included talking points and background there. It shouldn't take more than 5 minutes. It's great if you can tailor your letter because they will be more meaningful than a form letter. Other resources are in our Guide to Advocacy, which again include draft letters, draft media releases, talking points, etc. The impact statements, which are posted at this link here, will take you to the impact statements that we have for each state. They're posted on our website. We also have a new educational outcomes brief, the connection between lead, low-level lead exposure, and our education system. And it talks about several new studies that point to the relationship between lead exposure and third-grade test scores. We know third-grade test scores portend a later dropout. So this is really important for bringing in political leaders that care deeply about education but may not have been aware of or engaged in childhood lead poisoning previously. I also wanted to mention that this new website is out. It's called Lead Risk Index, and some of you may have looked at it before. I just did one query here to look at Hal Rogers' district in Kentucky. It's District 5, and it will give me, for his district, the number of kids that have blood lead levels above 5, the percent of kids with blood lead level above 5, the housing in his district. So this really enables you to take a very tailored approach to the communications that you're having with these political folks to tell them what's going on in their very own backyard. So I'd encourage you to take a look. It's leadriskindex.com is the main site. This was developed by the National Minority Quality Health Forum, Dr. Gary Puckrin. These are not surveillance data. These are not NHANES data. Specifically, this is a predictive risk index. So they're predicting what the likely numbers are, or the likely percent. And so I think for the epidemiologists on the line, it would be great to have you guys corroborate the data in there, because I know Dr. Puckrin's very interested in working with states to perfect this. So if for whatever reason the numbers for your zip codes, county, state, etc. do not correspond well with the data that you have, then I think he would want to know about that. I want to go back quickly. There's some questions. When we talk about 350 people losing their position, I think it would be interesting to define the impact of the community due to the loss. Same thing regarding losing surveillance capacity. Comment from Brenda Reyes. Thanks, Brenda. So being sensitive to time here, I'm wanting to make sure that our other speakers have a chance. I want to just move into then these innovations that we've talked about. So what can state CLIP programs and others do to find other sources of funding? We know, for instance, in Washington, D.C., you probably saw a LEDNet post from Pierre Herbal that said that their law enables them to bill a property owner for the services they provide as follow-up for a lead-poisoned child. We're going to hear about Ohio's work with their Medicaid office to cover certain services. Then we'll hear from Tom Carroll about a Medicaid waiver that they're applying for, proposing in the state of New York. And then finally, we'll hear from Delilah about the case management work that's being done through a community health center, 16th Street, it's called, in Milwaukee, Wisconsin. So with that, I'd like to turn over to John.
Well, thanks, Rebecca. It's a great pleasure to be able to join the panel during National Lead Poisoning Prevention Week. And I appreciate the opportunity to share a little bit about what we're doing in Ohio. The importance of sustainability of childhood lead poisoning prevention and healthy homes programs just can't be overstated. I'm going to throw a number out, and that number is $734,314. And that's just to get it off the top. That's how much money state fiscal year 13, the Ohio Healthy Homes and Lead Poisoning Prevention Program, will be receiving from Ohio Medicaid. Now, that's not Medicaid reimbursement. These are direct dollars that we can draw down for services that we've designed and choose to implement within the state. $450,000 of that is dedicated to public health lead investigations, lead risk assessments for children with elevated blood lead levels, and $284,314 of that is directly to supplement staff salaries within the Ohio Healthy Homes program. And the importance of this Medicaid money can't be overstated, but it just didn't fall into our laps. And that's what I'm going to talk a little bit about over the next couple minutes, is how to work with Medicaid and maybe how to obtain some money. I think we all are good at doing services where we can receive reimbursement for whether it's a finger stick or laboratory analysis or medical case management. It's a lot harder to actually get Medicaid to provide lump sums of money on an annual basis. And we didn't start this yesterday. We started about 12 years ago working with folks over at Ohio Medicaid, and I know how hard that is. We don't know anybody. We need to knock on a lot of doors. We were very fortunate in that very early on, one of the folks that I had an opportunity to work with at Ohio Medicaid, actually she and I worked a similar position in other jobs before I joined the Ohio Department of Health, and she joined Ohio Medicaid. But the importance there is relationships, because as people move on, we have to maintain those relationships and to keep these agreements flowing. The most recent agreement, though, that we've been successful with, and I'm overwhelmed with it, as CDC was directing us to find some sustainable funding, look around for other funds, we're sitting here brainstorming